everyone. My name is Mackenzie Clark. I am a clinical supervisor, pharmacy supervisor at the University of California, San Francisco. So I oversee the team at our institution that does prior authorizations for all of our specialty clinics and have been working with CenterX on our EPA and RTPB integration.
Hey folks, I'm Matt Schaefer. I'm president at CenterX, and I'll talk through a little bit of sort of what is real-time prescription benefit, how that flows into prior auth, and then we'll talk a little bit about what the benefits are. So I think if you think about the provider workflow, right? Patient comes in, sees a provider, the provider says, okay, I'm gonna think about putting a patient on a particular medication. Well, in the previous world, there was lots of barriers to that, right? One of those is not understanding what are the patient's benefits? Does that medication require prior authorization? A bunch of information about that. So what we do is we go out to the payers, to the PBMs, we get that information, we get it in front of the provider right there in the workflow. And the first step in that is what's the patient's out of pocket? Does it require prior authorization? A bunch of other information about that. There are lots of benefits to the PBMs in that as well, in order to, one example of that being providing alternatives for that patient. And then if the drug of choice does require prior authorization, then it kicks into that prior authorization workflow sort of seamlessly, goes out, brings in the prior authorization form, and then allows for electronic transmission.
So kind of as Matt explained, a lot of this is really to reduce administrative burden. Especially a lot of institutions are working on centralizing this because it's usually not the provider that's doing this. And so we really want to reduce the time needed to do prior authorizations. And kind of as mentioned, the first step, what we call RTPB, is when it's ordered to really be able to make that decision, save everyone time. Oftentimes patients don't pick up medications because the cost is too high. And a lot of times providers don't know that. So being able to have that real-time discussion with your patient right in front of you is super, super helpful. And as mentioned here, we've seen about a 50% change when the provider can actually see that there's an alternative that is different. That really relies on the data coming in being accurate and being able to actually have the logic to look not just at a static report, but actual real live cost changes. It also allows for avoiding prior authorizations. So time at the provider's office, I don't have to do prior authorizations if I know I'm getting the preferred coverage. When you see 20 different patients in a day and you have 20 different insurances, it's really hard to know which drug in a class is covered. So it really reduces that time on everyone. And just time saved, just having to try to call on prior authorizations, find those statuses, use that find that fax black hole. If it even actually went to the health plan, then you have to fax it, then you have to call them to see if it actually got it, and then same on the reverse side.
Yeah. So sort of expanding on a couple of those, the previous ways of doing that required a formulary and benefits file. They weren't patient specific. So the thing one is, if we go out for a particular patient and look, does this require prior authorization, that just reduces the number of sort of prior authorizations that you didn't have to do in the first place. The second piece is when we're showing, hey, provider picked this medication, there's another medication of the same class that doesn't require prior auth, and it may be just that the provider didn't understand that patient's particular benefits. We're seeing that 38% of the time, the provider's like, oh, yeah, I just picked one in that class. I'll go ahead and use that one that doesn't require prior auth. That gets my patient on that medication faster. That's better for everybody. Often that's a cost savings both for the plan and for the patient as well. So that's really important. And then sort of after that, as Mackenzie was just saying, then once you get onto that medication that does require prior auth, right, in the other 62% of the time, then having an electronic connection sort of takes that out of faxing. And then we also have some technology on the back end that even when it goes through sort of the happy path of those electronic connections, there are sometimes still faxes. And so we're sort of, managing that through technology and bringing them all sort of in and making them electronic and bringing them into the chart. So you don't have that same you don't have to manage both a manual workflow and an electronic workflow. So anyway, through all those, lots of different opportunities for savings.
So at UCSF, I think one of the biggest things with any type of technology is getting the end users to use it. So the benefit is that it does come in, it's right in our EMR, and so you don't have to go into any other platforms. This really, really helps. Like I said, a lot of times you have to register patients, you have to remember multiple platforms and passwords, which is always a challenge. And so what we're trying to do, though, is really get everyone to adopt it. It's a total shift in how you do prior authorizations, and so sometimes people revert back. So there does take a lot of effort to get people trained and keep managing that. Additionally, what we're doing is using the data on a larger spread, coming back from CenterX to say what was getting closed, what was staying open, what are we seeing in trends, and also targeting providers or groups to see ways we can actually optimize our prescribing patterns as well. And then also taking it back to the health plans to, when we're looking at the technology piece, to make that logic work a little bit better and get more real-time data, as some of our payer partners still give us static files, and so it's not actually real-time. So we can see the differences when it actually is data sharing to its full capacity.
Yeah, absolutely. And then sort of outside of what we're doing specifically with UCSF, there are lots of opportunities technologically to expand on what we're doing. So everything today is within the pharmacy benefit space. There are lots of drugs and medications that are covered by the medical benefit space, specifically on oncology and injectables in the office and those sorts of things too. And those should follow a very, very similar workflow. The challenge is the data is often in a different place, right? There are delegated benefit managers that work through those processes. And so there's lots of opportunities from a data perspective to bring all of those pieces together. And obviously we want to continue to expand and cover the entire market, right? The more electronic connections we have, the better that workflow is for our providers. All right. Thanks, everybody. Any questions before we step down? Yeah, sure. Good question. The question was, have we considered providing alternatives before the provider considers the medication versus after? And actually, I think we find a good spot today. From a workflow perspective, the provider has chosen a medication, but they haven't that hasn't been e-prescribed out to the pharmacy yet. So they've said, I think I'm going to put the patient on this medication, and they can either manually click a button and say, I want a little bit more information about this, or we can set up some logic, some rules to say, when they click sign, let's take a pause. Let's make sure that's the drug that they want to order for that patient. We're going to give them some more information. And then if they want to proceed with that, great. And if they want to pick one of those alternatives, we work within the EMR context to make that really easy. Does that answer your question? Yeah. We find that from a payer perspective and a PBM perspective, there's significant savings related to that behavior change, because at that point, before the prescription goes out the door, before the pharmacy is having to call back and say, hey, we got this drug, but the patient just showed up, they can't afford it. Is there another one that's, better for the patient, that's a little bit cheaper, and sort of work through that process? That's happening before that prescription actually gets e-prescribed.
There is a button, though, that you can go. So sometimes I'm getting queried by the provider to say, hey, what do you think we should order? And I can go in without ordering and kind of use the estimate button. It's like an estimate button to see what's out there. So I think that's kind of querying again, but not at the time of ordering. So you can kind of do it independently as well.
Yeah, there's other ways to use that workflow as well. There's meds to beds programs, right? You can queue up all those medications before a patient goes home from the hospital and run it and have that conversation from a pharmacy perspective and say, oh, hey, we're going to send you home on these. Well, this is how much it's going to cost. Here's your pharmacy of choice, and sort of walk through that process without, again, just sending them home and finding then there were medications they couldn't afford. So it just sort of allows you to manage that a little bit more upfront. And I think we're out of time. Thanks, everybody.